Now currently I'll be talking about stomach. Now what is stomach and why we have it? It's primarily a reservoir. And the job of this reservoir is to keep the food for a longer period in an acidic environment so that there are certain functions which should be carried over during the stay of our food within our stomach. Now we need to know what is the location of the stomach. But before you look at your objectives, now when you have a patient with you, and if you look at his abdomen, let's say you are an intern, you are in a hospital, you receive a patient in the evening, and now you are the boss. You are working in some remote area, let's say in Riyadh, where? Majma, Shagra. These are outskirts of Riyadh. And small towns, neighborhoods. You are there, you receive a patient. Patient has pain in his abdomen. Now you are a new intern. You need a lot of expertise and a lot of experience. So you did initial workup and now you're calling for help. It's mid of the night. You're calling your superior and he said, what's the problem? I have a patient, a young guy, having pain in his abdomen. Where? Sir, pain in the abdomen. Which part of the abdomen? Third time, you'll say abdomen. He may start shouting at you. Tell me, abdomen is a big area. So how you can prevent that? And what do you need for? You need to think an abdomen with these lines and boxes. But we are not supposed to draw on the patient. It has to be in our brain that these boxes, they give us certain locations. And knowing these locations will help us to understand the problem in a better way. And as you grow deep, you will learn better. If you are working, if you are operating at a 4th year, 5th year student, you have a different approach. When you are working as an intern, you have a different approach. When you are working as a resident, you have a different approach. So your knowledge is being upgraded. When you reach your chief resident, you have approached differently, and once you're becoming a consultant or a specialist, your approach is different. Because years are adding what? Some more understandings. So these boxes are taking us for better learning. Now we all know, in our abdomen we have tons of these organs, but we exactly need to be precise. So for that reason, we need to divide. Once you're in a hospital setup, we should divide 4 quadrants. You need to know 4 quadrants. Not only these 2 lines, but who lives where. Are we clear? So this is must know. Now, your level up. Your level up, you know these organs, but you want to know more about them. So, what are you doing? You are making more lines. Right? Then you are able to say, this is epigastrium, this is umbilical region, this is suprapubic region. Right? Level up. We all know who lives in the epigastrium. We all know who lives in the umbilical region. We all know who lives in the suprapubic region or hypogastric region. But still we need to memorize a lot. Don't we need to know more about it? So, connect to that. Anything which gives you a pain in the epigastrium is coming from where? Foregut. My intestine comes from 3. Tube becomes foregut, midgut, hindgut. And then I have a different artery for foregut, I have a different artery for midgut, I have a different artery for hindgut. Then nervous system is the similar thing. So foregut derivatives, they present with a pain in epigastric region. Midgut derivative region, regions, they present pain around or in umbilical region. And hinder derivatives, they present with the pain in suprapubic region. Now, who is the artery of foregut? Celiac artery. It controls all those who are living, who are presenting in epigastric region. Their artery is celiac trunk. Those who are living in umbilical region, their artery is superior mesenteric. And those who are living in suprapubic region, hinder derivatives, their artery is inferior mesenteric artery. Are we clear? And if we add up more, the pain from epigastric region, which segment of the spinal cord this pain will be radiating. So that tells me why a pain of appendix, it goes around the umbilicus. So why the referred pain is going there? Why not where this appendix is originally located? So this understanding, it's been growing up as you are progressing in your life. And you need to understand. Are we clear? Yeah. So now let's come back. Now we know our stomach. It lives in right upper quadrant, right hypochondrium. Make sense? Across transpyloric plane. Left hypochondrium, transpyloric plane. So this is the location for the stomach. When we look at the stomach, we said there are different parts of the stomach. So the different parts of the stomach, we can see that this is esophagus, this is the cardia, this is the fundus, this is the body, that is the pyloric area, that's the duodenum. There is a curvature, one is small, one is big. So let's label it. Are we good? So outside, now a histologist, Khalid Mohammed, looks at the stomach like this. How the muscles are arranged and how the glands are arranged. Are we good? Now when you go to the dissecting room, operating room, your stomach is something like this. And when you open up, you'll see a lot of rugaes, this pattern. Are we clear? Same thing. Are we good with this? Now, when your patient comes to you, he tells you, you understand left-sided pain in left upper quadrant, left hypochondrium. What do you do next? You touch and feel. But you want to know something. Will you open him up? No. You order some investigation, some CT scan, after doing necessary ultrasound. Guys, there's a sequence. So, but more useful, more, which gives me the most, I'm talking only about most relevant things. So, I like to have a CT scan. So, how I interpret a CT scan? So, the same stuff, I should see that my stomach is been painted orange. So, what are the neighboring organs? You can see the liver, you can see the spleen, you can see the pancreas, you can see the aorta and inferior vena cava. Make sense? So you need to have this orientation. Once you are given a CT scan, then you can understand. Yes, what's your question?
Why is it flipped? Usually left is on.
Yeah. It's flipped on purpose. Now, you have removed the skin, you're looking from front. On top there is a diaphragm, on side there is a costal margin. This is the liver. Liver being reflected upwards. Otherwise, this whole space is covered by liver. Guys, can you see on top there is something written? Supracolic compartment. What the hell is this?
Above the colon.
Which colon? No?
Ascendant?
No?
The whole?
Mesentery of the transverse colon. Transverse mesocolon acts as a divider. It is coming from parietal peritoneum layer, which comes from the posterior abdominal wall, and its anterior edge, I have the transverse colon, which is surrounded on both the sides, and this mesentery goes back and it splits up. In between this mesentery, I have the vessels, nerves, lymphatics. Those who have to supply my transverse colon, they travel between the two layers of this peritoneal fold to reach, to convey, to carry all what is needed for transverse colon. So this mesentery creates a shelf, a ruff. Above to it, we call it supracolic compartment. Below to it, we call it infracolic compartment. There is only one tube, there is only one organ which travels from supracolic to infracolic, and that guy is duodenum. The second part of the duodenum, it travels from supracolic to infracolic by going through this layer. Otherwise, the supracolic compartment organ, they live above to this sheet, and infracolic compartment, they live below to this sheet. Are we clear? So now we are looking at liver has two lobes, right and left lobe. Let's label it as different lobes. And there is a gallbladder. Caudate and quadrate lobe of the liver. We'll talk about liver in detail. I think probably our last GI lecture is about liver. This is where stomach lives. But if I release this liver down, a lot of stomach will be covered. Then what do we have? Let's label it. We all know this is abdominal esophagus, body of the stomach or stomach. Are we clear? And you're looking at duodenum. What the hell is this? Lesser omentum. What is lesser omentum? Anybody has a board marker? Guys, can you see this board? This is my liver. This is my stomach. So, parietal peritoneum. It stops from the posterior wall Make sense? Yes. Now, this fold of the peritoneum, this is lesser omentum. Lesser omentum, mesentery, you can say anything, but we have specific name in different areas. And this guy down is greater omentum. And what are they? They are two layers of peritoneum. Peritoneum. How many layers does peritoneum have? One. It is one layer structure. Don't make a mistake. Peritoneum is like a balloon. It's closed. All the organs, as you grow, they invade. But how they invade? One organ is here, one organ is here. Is there anything inside this balloon? No. So this balloon, you are just pushing it in, but you are not inside this balloon. So peritoneum is one layer, but you push on that, so it becomes two layer. The one which close to the organ is called visceral layer, and one which close to the body wall, we call it parietal layer. Are we clear? So this yellow guy is the lesser omentum. Are we fine? So this lesser omentum, primarily it's a fold of mesentery. It's the fold of peritoneum. So part of it, it's coming from liver, going to stomach, Can I say liver as hepatic?
Yeah.
Can I say stomach as gastric?
Yes.
Can I say the part of this fold, part of this mesentery, part of this omentum, which comes from the liver going to the stomach, hepatico-gastric ligament,
Yes.
and the part of this fold, which is coming from liver to the duodenum, hepatico-duodenal ligament?
Yes.
So we distinguish this into two parts, otherwise it's one thing. And we call it lesser omentum, hepatico, gastric and duodenal ligament. Are we clear?
Yes.
Now there is one more concept. I need your pen again, sorry. I should not have written. No, two are enough. Two different colors. Okay. Don't forget one thing. Peritoneum, I told you it's a balloon. So this one balloon is this one balloon or two balloons?
One.
I just press it here. So, can I call it lesser sac?
Yes.
Yes.
Can I call it greater sac?
Yes.
This place, omental foramina, epiploic foramina Winslow. Are we clear? So, if I approach from here, I'm entering to lesser sac. The rest of whole of the abdomen is greater sac. Are we clear?
Yes.
And if you understand this, you're done. There are so many things. If you want more detail, I think I have some hand drawings. Watch my video. It will be very clear there why and how and what happens. So this yellow thing is, inside it I have lesser sag, and this is lesser omentum. Now, and this opening, I'm talking that opening, this opening is foramina Winslow, epiploic foramina. Okay. Do we all know Pringle?
Yes.
If I use the word Pringle, everybody knows it's a chips. Or have you heard anything else with the name of Pringle? No. If anybody does, let me know. Have you heard any other thing with name of Pringle? No. But I have one more thing, which is Pringle. And that is Pringle maneuver. What the hell is this? From where it has come? You're a surgeon. You're operating on this guy, gallbladder. You're trying to chop him from here. While doing that, you might damage the artery, and it happens. It's very tiny space. Small thing, you may damage it. You may damage it, you'll see a gush of blood painting your face, or your assistant face, or the light. A tiny looking artery have an immense pressure. So, if that happens, everybody will go in panic. But surgeons are mostly smart. That's why they are surgeons. So what they do, they put their finger, because there's a hole. Do you know I'm in greater sac? And on the other side is a lesser sac, and this is an opening. Can I put my finger here? Inside, one finger upside. So in between my finger and thumb, I'm having hepatic artery. Hepatic artery gives a branch which gives gallbladder. I'm controlling, I'm pressing on hepatic artery. Will bleeding will not stop?
It will stop.
That is called Pringle maneuver. Are we clear? Just clapping, just pressing. That's it. You want to see? I think one of my videos is labeled as Pringle maneuver. It's filmed on a cadaver. So you just go and watch that. It's being demonstrated on that cadaver. How we bring this Pringle maneuver. You know, once bleeding will stop, you can fix the artery, you can sew it, you can suture it, and you can save a life. Are we clear? So this was lesser omentum. I hope we know about it. Now I told you, and I've shown you on that picture also, but I've drawn from the greater curvature. These two layers which are coming and enclosing my stomach, now they will fall down like a curtain, like a sitara. So that is my greater omentum. Lesser omentum, covers the liver, become greater omentum. And this greater omentum, we love to ask you in hospital. How we ask you? Identify what is its function. It's a policeman. How it is a policeman? If your intestine is any part of intestine rupture, okay, someone has an appendicitis. Appendix get inflamed. Appendix got burst. Now, when appendix got burst, what will come out of this appendix? Only bacteria? What do you have in your intestine? Feces. Brause. So, will not be coming into your abdomen, into your peritoneal cavity, and remember, if that happens, your patient may develop peritonitis. And peritonitis, surviving after peritonitis, you must be having a big support of God on you, or you must be having big blessings. Then you may survive in big centers of this world. I'm not talking about Batha or Majma. I'm talking about big centers of this most advanced center of the world. Survivor of peritonitis are less because it's a very bad disease. So this greater omentum, it goes and it covers it. It goes around and surrounds this appendix. So now no more spread of the fluid which is leaking from the appendix. So it walled off. You know, when there is a crime, police come and they close that area. No one is going in because they want to collect the evidence. So we'll have to ask this. Right? But we'll have to ask one thing more, and that is a must ask. This epiploic foramina or mental foramina Winslow, in its anterior free border, we have three structures. Posteriorly, we have one structure. Superiorly, we have one structure. Inferiorly, we have one structure. Which of the following structures? I'm telling an MCQ. Which of the following structures are running in the free border of foramen ovale? So, which of the following? I'll give you 5. One is right, 4 are wrong. Which one of the following is contributing to the posterior boundary of foramen Winslow, superior boundary, inferior boundary? So 4, 5 MCQs are ready to go. Are we clear? Now, this greater omentum has blood vessels, everything, and we also use for other surgical purposes. But let's not go in detail because this year one babies. So let's not get into other ways. Are we clear so far? Now you're looking at transverse colon, the two bends of ascending colon and descending colon. Under the liver, hepatic flexure. Spleen will come here, splenic flexure. Bending of my colon, ascending colon bends to become transverse. Descending colon bends to become splenic, and they join together to give us transverse colon. Are we good? So there is now kidney. Liver and kidney. Guys, do you remember in the beginning I told you? Supracolic compartment, infracolic compartment. Only one guy can travel. But on the side, only on one side, right side, we have a channel through which any secretions from supracolic enter into infracolic or infracolic enter into supracolic. And that pathway, that doorway is being here. So this is the spleen is fine. We talk about this guy, that's not a problem. Yeah, this red circle. This red circle is Morrison pouch or hepatorenal pouch. And that is the gateway, very important area. That is the gateway which provides a communication between. Umar, what's the problem?
Oh, I'm sorry.
So how we can walk from supracolic to infracolic? So that's the only way. Guys, are we clear?
Yes.
We were here. Anything new? I want to know where Umar is sitting. How I know? If I want to know where Umar is sitting, what should I do?
Look at it.
I should lift the Umar and see where he is sitting. What is underneath? Yes or no? Correct me if there is any other method, guys. Do we have any other method?
We can look at the people sitting next to him.
I want to know underneath you, and you want to see, look at the others.
Oh.
Why?
Oh, okay.
Got it? I want to see what is inside your pocket, and you are telling me look into my neighbor's pocket. Will it serve the function? No. So what we'll do? We'll lift the stomach. So now, what we have done? We cut here across this greater curvature of the stomach. Once we cut here, now stomach is lifted. Is it lifted? Huh?
Yeah.
Is it not lifted?
It is lifted.
It is lifted. Now can you see who he was sitting on?
Pancreas.
Pancreas, transverse mesocolon, transverse colon, splenic artery, suprarenal, left kidney. There are so many guys here, celiac trunk. So these are 9 structures. And we call them, these are the structures who make stomach bed. Sarir for stomach is made by these 9 structures. How I can ask you this question? Which of the following contribute to the stomach bed? Put 1 from here, 4 from somewhere else. Make sense? Tamam? Don't no ask a big question. La, la, and I want the piece. Yeah.
It was an OSCE and I tried pancreas. So I lose them up.
Habibi, it depends on what I'm asking. If you write here, tail of the pancreas, I will think about you. But if you write pancreas, you are fine. If you want to write body of pancreas, you are good. But still, it's okay. But if you write head of the pancreas, you get 0. If you write tail of the pancreas, very questionable. Yes, this guy is knowing, but he probably is knowing more than what he should not know. There is a limit of knowing. If you know more than that, then you can kill yourself. Got it? You know this overcorrection? I can tell you, when you are looking at any MCQ, what is your first thought is always right. When you change it, trust me, you are making a mistake. When we grade your OSCE questions, you did right answer, then you erase it. Then you're putting a wrong answer. I don't know who is that super guy who comes and tells you, no, you are, why you are getting marks? Get 0. And a lot of you does this. And even when we look into exams of, it shows us that if I want to look at how much time you spend on each MCQ and how many times you change the option, I can see that. Got it? It's visible. Not to you. Are we clear? So let's label them, we know them. I hope you will not say tail of the pancreas. Huh? Okay, so this is where stomach is missing. Are we clear? You are looking at stomach bed from the front. You are looking at stomach bed on a section. Something in between this orange line. Are you happy now, Umar? It's not other way around. It's not flipped. And then on a sagittal view, you can see this is where my stomach bed is. Are we clear? This is 12. Now, I'm putting an endoscope into the stomach and I've reached to the duodenum. I want to see the different parts of the stomach. Where I am. You can guess. Cardiac end. Why? Because I can see my scope. I just tilted my eye backwards and I can see the scope coming up and the pattern of Brugge is still making. Can you see more organized? I'm somewhere in the middle part across a curvature. I'm close to the pylorus. Brugges are almost gone and I'm at the pylorus. Pyloric sphincter. Are we good? Ask 2 questions.
How did you lose the cardiac on the first photo? acting on top of the scope.
Yeah.
How do you know this is a cartilage specific?
First of all, I'm putting the scope. I know how much distance I am. Second, you know what I do? No, it's not. I'm going like this and I'm seeing like this. It's a front view. If I bend him, can I see this tube?
Yes.
So I'm looking at the tube. And basically, idea is not to look at the tube. Idea is look at the cardiac end of the stomach. Like, when we do this endoscopy, when we are hunting for any pathology, it's not like, oh, let's do it gastroscopy for fun. No. It's being done for some diagnosis, to detect some problem, to pick some problem. Jawad, are you okay? You look scared. Are you fine? Now, we were here. Who's this guy? Abdominal aorta. Mashallah, you guys are smart. So abdominal aorta, it gives a branch here. Celiac trunk. Celiac trunk give me 3 branches. One for liver, one for spleen, one for stomach. 3. Okay. Where's the liver? So this guy is going to the liver. And then I can see that this one is dividing. One is up, one is down. One is very specific for liver, Haas. And one is going to the duodenum and stomach. So, can I call this guy common hepatic, a big hepatic? Yes or no?
Yes.
Okay, you are good. Hepatic. Okay, hold on. Guys, don't. What is coronary means? Heart. Coronary means heart. Hepatic means liver. Cystic means any rounded thing. So you have cystic artery for gallbladder, you have cystic artery for urinary.
My bad. I meant portal. What is
Po-
portal?
Portal.
Yeah.
Portal is primarily a vein which never goes to heart. First, it goes to somewhere else. That, this definition I think I learned when I was in grade 9. What is a portal vein? A vein which does not go to the heart, it goes to another organ, it breaks up into sinusoids, and then it reforms, and then it drains into the heart. Are we clear? So, celiac trunk we know, and we are looking at the common hepatic. Everybody agrees?
Yeah.
Jawad, you agree? Or you have any other option? Good. Now, this one is going to the liver especially. Can I say something more specific? Hepatic proper, will it work? So I'm calling it hepatic proper or proper hepatic artery. Are we fine?
Yeah.
My liver has 2 lobes, right and left lobe. So hepatic proper, I need to divide it for 2 lobes. Left hepatic, right hepatic. Make sense? Next to right hepatic, I have gallbladder. So I need to get a branch for gallbladder, cystic artery. Make sense? And this one, which is going towards the duodenum and stomach, can I call it gastro-duodenal artery?
Yeah.
Are we good so far? Now the problem comes. Jawad, something fishy for you. Be ready to type your email for me. There is one artery which is going to stomach, and it has choice. It may come from here, it may come from here, or it may come from here. So this artery, this is right gastric artery. So please, whatsoever, whosoever, say that it's not a controversy. It's an option. Are we clear?
I don't understand though.
You don't understand. My dear friend, I need an artery to supply across this lesser curvature of this. And it can come from here, it can come from here, it can come from here. Because different authors talk differently. Are we clear? Now just pay attention here. Who's this new guy? Portal vein. And where is inferior vena cava? Can you see him? Make no mistake. Now the gastroduodenal artery is going behind the duodenum towards the stomach. Are you fine? So this is that artery what I was already announcing. I am bringing him from hepatic proper. Can you see someone coming from hepatic proper? Going towards the lesser curvature of the stomach?
Yeah.
I call him right gastric artery. Are we clear? Now there is someone who's going high up, leaving from celiac trunk, supplying the lower esophagus or abdominal esophagus, and then running across the lesser curvature and then shaking hand with the right gastric. So this one is the left gastric. And it gives, when it's giving branches to the esophagus, these are the esophageal branches. Are we good? Clear? Now I have splenic artery. It runs across the upper border of my pancreas. Yes?
So, left gastric artery forms anastomosis.
Left gastric artery and right gastric artery, they are running across the lesser curvature. They join face to face, and both of them contribute to supply the lesser curvature of the skull. Obviously, left gastric has big contribution, right gastric has small contribution. But I'm not asking you who's giving more blood. Guys, are we clear? So now you have looked at this splenic artery, which is tortuous. And now we can see some more arteries. This splenic artery gives a branch which runs across greater curvature of my stomach. I call him left omental, epiploic. There are so many names. So left gastro, epiploic, left gastro, omental, whatsoever you write. So I left no choice for you. Are we good? That is across the greater curvature. But still I have a lot of area on greater curvature. So from this gastroduodenal artery, look, see what he's doing. He's also now joining the left gastroepiploic artery with the name of right gastroepiploic. Are we good? So now let's sum up. Lesser curvature, 2 arteries. Greater curvature, 3 arteries. We have seen 2 only. Right and left, right and left. Are we clear? Then we have this gastroduodenal goes and supplies. We will not be talking here at the moment, because when we will be talking about blood supply of the pancreas, then it is, blood supply of the pancreas, it has double supply. Because half of the pancreas, head of the pancreas, half of it comes from my foregut, half comes from my midgut. So that half which comes from foregut will get its blood supply from the celiac, and the half which comes from the midgut, it gets its blood supply from the superior mesenteric artery. But this is not our topic today, I'm just mentioning it here. Yes, Jawad?
When does the right gastroepiploic start?
When they start, it's a branch of your gastroduodenal artery. That's it. Are we clear? This is my superior mesenteric artery. Now short gastric is the guy which is coming from my splenic, that covers the fundus of the stomach. Are we clear? Can you tap on him? You are sitting in this classroom. No, don't look backwards. Look at me. You are sitting in this classroom, so busy, and texting whom? I'm doing a great job, Dad. I'm sitting in a class. Teacher is doing everything wrong. So just focus here. Get some benefit of sitting in the class. Otherwise, sit outside. You want attendance? Come to me, I'll give you. Yalla, Balash. If you are here, pay attention. Guys, are we good? So now let's revise. Now it's your time to talk. Who is this? Why right? Left.
Left gas.
Very good. Very good. Who can fail you? Trust me, wallahi, our intention is, I love people going. I don't like when I see someone is repeating. Trust me, I hide my face from him that I should not give any bad feeling to this guy intentionally or unintentionally because poor him is already suffering. I love your progress. Trust me, it's from my heart. So what is this? What the hell is this? What is this artery, Jawad? This is a question for you. What is this yellow dot? Where is Fawad? Fawad, you're back? Yeah. Everything fixed?
Yeah.
Uni is working, all gates are functional,
Yes.
everyone is doing his job. Thank you. So now, what is this yellow dot? If your patient, guys, this MCQ, I think I'm looking at this MCQ for last 30 years. An MCQ made on this yellow dot. Patient has duodenal ulcer, and this duodenal ulcer has eroded the posterior wall of duodenum. While it was erasing or destroying, it has involved this artery, gastroduodenal artery. Now, which of the arteries been damaged? And I can give you 5 options. One of the right option is gastroduodenal. If a gastroduodenal ulcer bleeds, which of the arteries responsible for this bleeding? Gastroduodenal. And I will mention first inch of the duodenum. The bleeding is coming from there. So this yellow dot is bleeding. Are we good? Superior mesenteric. Right and left. Are we good? Tamam? Now the venous drainage of the almost similar. Only you need to memorize. Just make an RP and you're good. Guys, this lymphatic is very important. 1, 2, 3, 4. And you should be specifically knowing where the area across upper area at the greater curvature, which group of nodes, which group of nodes, which group of nodes. Very nice MCQs are sitting looking at. Are we good? Guys, the stomach is supplied by vagus through its different branches. 100 years back, one of the biggest cause of deaths of humans was ulcers. Now, around 70 years back, there were certain medicines, they came in picture, H2 receptor antagonists and all those stuff, and by their invention, that era is gone. So now, people are not dying because of this is a normal stomach, and a gastric ulcer.
I have a question in the previous slide. In the previous three areas of exam. Is cancer most common in curve number 2 or area number 2?
It depends. It depends. Japan, #1 country in the world for gastric cancer. So in Japan, the doctors, their teams are running in their towns and neighborhoods and small villages with a gastroscope, and like they are coming as a camp format, and the whole generation is being scanned and scanned and scanned, and they are putting endoscopes because gastric cancer is so common there.
What's the antrum?
There are so many things. You are inviting me to get into pathology, and I'm trying to avoid it because you are a class of first year. It's my favorite topic. I can. You want? Lesser curvature is more prone for ulcers, more prone for cancers because when we drink, trust me, we should not believe that should not be our practice. But what our religion says, when you are drinking, sit down. You know, we all believe in that. We were all taught like that. Why? If you are standing and drinking waterfall, the gravity effect is more and it hits your lesser curvature. Lesser curvature is more prone for ulcers and for everything. If you sit down, the gravity effect is minimized. But we should not believe what we are asked to do. Okay, so people develop ulcers. Now the time when we were treating ulcers, those who were bleeding like hell, chopping away the stomach. So then, from where these ulcers were coming, by the way? Acid. Acid. Who promotes acid? Drugs not. So, what do you do? Can you see what I've done? Chop, 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 chop. Selective vagus nerve branches are cut. So vagus is being cut, not full. Selective cutting. So you are decreasing acid production in a person who has the problem. It was before those medications, omeprazole and all that stuff. Before that. So highly selective vagotomy and all those things. So vagus was cut and people were relieved. You do the surgery, you cut the vagus, not the main vagus, but branches of vagus, and your patient get benefit. He can live for some good years. Are you fine? It's not a cancer. Are we clear, guys? Hiatal hernia we talk about. The right crus malfunctioning. We have types of, but I don't think you need to know the types. It's not like for you. But if you know hiatal hernia, how and where it is formed, yes. Huh? I know. Can I tell you one thing? I'm surprised. I was just recently watching this MSI exam paper, and I was surprised to see most of the things which we teach in first year MSK block, they were all the questions for MSI block, which is now conducted in year 2, your second block after PU. Anyway, so guys, this slide is worth for an Anki. It has everything. Zubda from whole stomach. Are we clear?
Yes.
So now we have put double contrast, air and barium. And then we can see the whole different parts of the stomach and everything. We call it barium meal. A CT scan, you can see the liver, you can see the stomach, and you can see this aorta and inferior vena cava. Are we clear?
Yes.
What is this? Ara, stop playing. What is this? Fawad will tell us. Fawad, what is this? This is a question for you.
This is the stomach.
MashaAllah, this is someone who was crazy. I will not say crazy like whom. But no, you not you. Someone who was crazy from here, a girl, so she was eating her hairs. And her hairs were deposited in her stomach. The stomach was full of hair. Ultimately, she was brought in, and then they have to open the stomach and they pull out this junk of hair. Full stomach. So hair,
I thought this stomach.
stomach. Right, listen to us. No. No, it is what a girl is written. 15-year-old is written here. Hada maktub. No, it's not. Guys, listen, you think only girls can be crazy. Boys, don't be gender biased. Are we clear? You know, this is not a story only. People eat nails. People eat, I don't know what kind of thing. People are crazy, man. Go eat food. Why are you eating this stuff? Okay. So now this is a section. You are looking at the liver, spleen, and the stomach. Make no mistake. Which end of the stomach is this? People used to write it. Right? So it's not fun. So make no mistake, okay? Are we clear here? Guys, you can talk after. What is this? We convert banana out of a stomach, gastric sleeve. We chop away the whole greater curvature, body, fundus, and patient is living with a banana. If you see someone who is big like me, and maybe after 3 months he's 1/4 of his size, so then gastric sleeve, and nowadays Ozempic. I can see people from their face. Guys, remember one thing. Ozempic is for patients. Which patients? Who are dying. Who are dying. So why Ozempic is given to them? So their death will be little delayed. So if normal people start taking Ozempic, so what are they doing? They are going for death. Don't. If somebody asks you, I know it's very expensive, Wazara Saha has banned it, and then still is available undercover, and a lot of things are happening, but this is bad. Are we clear? And remember, those who get gastric sleeve, take my words, if you don't change your habits, this stomach will go big again and you will go big again. So don't think, I got my stomach out so I'm done. No, you can be big again. Are we clear?
Do they lose appetite when they...
No, vitamin B deficiency is one of their major things because poor them they can eat very small. They cannot go beyond. So there is no storage. So you'll see someone who was enjoying 2 big platters now living on 1-2 tablespoons. You can very easily see, oh man, you are. And no one will say because it's been done through laparoscope, so you cannot see any scar or any.
Doctor, what do you mean the stomach can go big again?
It balloons up again.
Like it goes back to its original
Yeah. Even bigger than that. Stomach is something you keep on dumping.
Doesn't it burst? Because it can't...
It depends. If you are doing in early stage, it
So you
will
will
burst.
touch me when
But it usually don't burst. I can show you. There are so many guys and girls in the uni. They got sleep done and now they are mashallah back on the go.
Just like the greater momentum is connected to the greater curvature, but when you take it away, what happens to the greater momentum? You connect the egg to the...
Zabala. Greater momentum, Zabala. Now patient is only, we have one cadaver down. When you come to the lab, ask me, I'll show it to you. Has a sleeve thing. You can see a banana in reality. Okay guys, any other question?
Monday.